Welcome to RetinaRA.org, a Vitreoretinal knowledge-sharing platform. This video will present Yamane Intrascleral Haptic Fixation technique from a Vitreoretinal surgeon's perspective. I am Dr. Gire Ersoz, and this case is from my archive. An 88-year-old female patient with a history of trabeculectomy and subluxated PCIOL in her left eye. First, we mark the insulin syringe tip entry points on the limbus and sclera. Since my patient is myopic, I marked 2.5 mm from the limbus. I also marked the insulin syringe tip entry points 2 mm beyond this point. I tried not to enter the trabeculectomy area while making trocar entries. I definitely insert 3 trocars in all of these cases and perform a wide core vitrectomy because retinal tears can occur in these patients. It is necessary to be careful not to leave any vitreous under the iris and under the lens. As you can see later, I continued with core vitrectomy. We will understand why we did this in the later stages. Then I made a 3.2 mm main incision from 12 o'clock. The pupil was very small. I tried to support the IOL from below with the light probe, hold it with forceps from the front, and bring it forward. Here, I turned it right and left with slight maneuvers and brought the front of the IOL above the iris. Now, I tried to save the back haptic. There is a 3-piece IOL here. As you can see, there were capsule and cortex residues around the IOL. A haptic was broken here. I cut and removed the IOL. I entered the anterior chamber again and performed vitrectomy in the anterior chamber. In these cases, when the lens is subluxated, there is a vitreous passage to the anterior chamber. I opened a 1 mm side incision. Since the iris was very small, I tried to widen it a little by pulling it from both sides. I am using a 27G injector tip and a Senza 3-piece IOL in this case. I definitely recommend that you check in advance whether the haptic enters the injector tip. There are surgeons who place the first haptic directly on the injector tip, but sometimes the leg comes out reversed, so I leave it in the anterior chamber first. As you can see, I advanced the injector tip by 2 mm and turned inside. Actually, the trick here, the point that will make our job easier, is to direct the tip of the insulin syringe above the iris. We placed the haptic on the injector tip with the anterior chamber forceps and took it out. I recommend that you hold the haptic immediately. During the cautery knob creation process, holding the tip of the haptic with a forceps from a distance of 1 mm ensures the formation of the most ideal knob. Then we made our second entry. I directed the second leg from the main incision with serrated forceps. Here, the haptic was slightly bent, but after you remove it, if you are using a suitable lens, the haptic returns to its original position. Again, we held the tip of the haptic from a distance of 1 mm and made a knob. Now let's understand why we performed the surgery together with pars plana vitrectomy. We are working under a small iris, and it is not possible to completely clean the capsule and cortex residues around the IOL. In this way, the pieces can fall down. I find it more appropriate to perform a pars plana entry, both to remove these and to check the retina for tears with 360-degree depression. In addition, the remaining vitreous residues around the IOL can cause the IOL to tilt.
You can share your interesting and educational cases on our website, RetinaRA.org. Don't forget to click the like button and follow our channel to be informed about our new posts.